Good evening, everyone. My name is Nomi from Netcare, and I'd like to welcome you all to our very first Healthy Dose session, your health and care session. These virtual events will allow you to engage with some of our clinicians. Every month, we'll be having a different session with one of our doctors. And today, I'd like to encourage you to please follow us on the social media platforms in order for you to be able to stay up to date with everything that we are working on and everything that we are discussing. Please note that any information that the doctors share tonight is not any medical advice, and please do consult with your doctor or a medical professional if you've got any concerns. Tonight, we will be discussing the beautiful journey of pregnancy, specifically your birthing options when the big day comes. We will be debating C-section versus vaginal birth. That said, it's an honor to host this event with our two guest speakers, Dr. Francois Retief and Dr. Paterson. Both doctors are obstetrician-gynaecologists with a subspeciality in urogynaecology, practicing at Netcare Park Lane Hospital. Dr. Paterson will provide insights on C-section birth, while Dr. Retief will share his knowledge about vaginal birth. Welcome, doctors. Please introduce yourselves. Dr. Francis Paterson first, followed by Dr. Retief.
Hi, everyone. I'm Francis Paterson. Thanks for having us. This is very exciting.
Right. Good evening. I'm Francois Retief, and thank you very much for the invite. It's a pleasure to be here.
Thank you so much, doctors. Before we kick off, I'd like to ask everyone to please mute and please keep your cameras off for better streaming. Please drop your questions in the Q&A section if there's anything you'd like to know about today's topic. Let's begin with Dr. Francis Paterson.
Okay. So Francois and I was chatting, and we thought it would be an interesting way of presenting this in a fun sort of debate form. So I am going to present a little slideshow on the pros and cons of Caesars, and also, you know, my own opinion on this. I think it's important that we're clear here, though, that I don't think either of us are pro either way of delivery. I certainly am not. I'm pro autonomy. I'm pro informed consent, and I'm pro mutual respect. And I think that's the main thing that we need to remember with these kind of things. So without further ado, how to have a baby. In summary, we are going to be chatting about the fact that there is no perfect way to have a baby. They both have their pros and cons, and they both have their indications. I'd like to also just make a note that all births are normal births. And we'll go into a little bit about the stigma at the end, but really it is quite, oh, sorry, I've had a problem with my sharing. Sorry about that. 2 seconds. No, still doing it. My apologies. Let's try it one more time.
Hi, doctor. So it was showing on our side.
I've got sorry, I just got a message that it was looking strange. There we go. All right. So yeah, all births are normal births. And obviously, I know this is an irritating rhetoric for people, but our most important outcome is a safe mom and a safe baby. We don't fall pregnant to have a certain type of delivery. We fall pregnant to have children, and we want them to be as safe and sound as possible. This is not a clear-cut argument. There are no black and white areas here at all. And I'd like to just touch on it at the end, is that should we even really be having a discussion like this? And I'll go into a little bit more in detail. So what can we agree on? Well, we can agree that national cesarean delivery rates of 19% are associated with lower maternal and neonatal mortality, so lower deaths of mums and deaths of babies. We know that countries with a lower cesarean rate than that have a significantly increased rate of maternal and neonatal deaths. And there are a lot of factors contributing to that, but one of them is poor access to a cesarean delivery. We also can agree fairly well that cesareans are better for premature and low birth weight babies, better for breech babies, better for multiples in some circumstances, and they are a necessary and life-saving procedure in times of an emergency. So why are cesarean deliveries on the rise? Well, look, this is a highly emotionally charged issue, and it is, you know, a space in which there's a lot of litigation and a lot of fear around these medico-legal aspects. It's also increased because of a widespread use of fetal monitoring. We use fetal monitoring because there is no better alternative, but we know it has a poor predictive value for detecting issues in babies during deliveries. We've also seen a massive decrease in forceps deliveries over the last couple of, well, sort of 20 or 30 years. And that's because forceps are extremely, extremely dangerous for the mum, and they can damage the pelvic floor. And obviously, there's been a big trial documenting the sort of safety of breech deliveries in Caesars and vaginal births. And that obviously has resulted in us doing less vaginal breech deliveries. Why are there so many points of view? Briefly, it is difficult to know in this who is objective, and I don't know if anyone is strictly objective. Is the health sector? Probably not, because they save a lot of money by not doing Caesars on demand, and that's in private and in state. And I mean, a lot of states, hospitals, even in the UK, won't offer cesarean sections as an option, even if they're medically indicated. Are midwives and obstetricians perfectly objective? Probably not. There's a good chance that, you know, there are obstetricians, and we know this for a fact, that there are obstetricians who are doing cesareans that are not necessarily medically indicated. And there are a number of reasons for that. And we also know that there are midwives who, you know, their livelihood depends on convincing us that we should be delivering in a certain way. And this isn't everybody. But, you know, we need to know that religious leaders, attorneys, everybody is giving us a slightly skewed, slightly subjective viewpoint on this topic. So there are lots of benefits of a Caesar. They are controlled, they are predictable, which is not what you can be said for a vaginal birth. They decrease complications such as permanent brain injury, fractures, brachial plexus injuries, and they decrease the incidence of complications for the mum in terms of severe perineal tears, which can cause prolapse and incontinence of stool and urine. Why are we objecting to these Caesars on demand in 2024? Well, the three main arguments are your complications, your economic argument, which is based on your utilitarian ethics and the scarcity of resource, and then your nonsense objections, as I call them, which we'll go into very briefly. So what are our complications? Well, if you look at the literature as a whole, you would see that Caesars are associated with increased mortality, maternal and neonatal, so newborns as well. They are associated with hysterectomies, increased placenta previas, and very sticky placentas that don't want to come off the uterus, which leads to postpartum hemorrhage, anesthetic complications, poor bonding, longer hospitalization. The list goes on, which we are going to discuss in a minute. What I'd like to just touch on, and I think this is one of the cruxes of this argument, is that the data is not necessarily, in this case, completely objective as well. Our current understanding of cesarean delivery outcomes is limited by the available data. We're looking at outdated studies which are poorly designed, inadequately powered. They don't control for confounders, and we'll go into these things, but they also importantly fail to differentiate between elective and emergency deliveries. So if you are having an elective controlled delivery for a reason, like you have, for example, a cardiac issue, or if you're choosing to have a low-risk pregnancy and have a cesarean delivery, or if you have an emergency Caesar, those are three very different things, and we have different outcomes from each of those groups. And it's important that we don't muddy the waters. We need to say, look, emergency Caesars have this complications. We can't just say Caesars as a whole have these complications, because actually emergency Caesar complications are vaginal delivery complications. And it's not fair. It's disingenuous to lump it all together. So we need to compare apples with apples. We can't compare emergencies emergency cesareans and vaginal deliveries. We need to compare planned deliveries, cesarean and vaginal. We can't compare private versus state sector data because they have differences in training, in staff, in resources, and access to care. And we can't compare the developing versus the first world. For example, a 2021 study basically found, even though they didn't want to, that planned cesarean delivery had lower risks and lower complications than vaginal births. And now this was really not what they expected. You can see even at the bottom here, the stigma that is attached to data like this. The main researcher said, I myself am challenged by the data. I wanted it to be the other way around, which is just so interesting considering that we actually should want to know the truth and not necessarily skew the data with our subjectivity. So looking at the complications, I'm not going to go into detail with this, but the maternal mortality rate from 200 years ago to now is indescribably better. Today, giving birth is 300 times safer than just like 200 years ago. And a lot of this is due to access and antibiotics, but a lot of this is also due to access to cesarean sections. This is just a slide. We don't have to go into it because we may be running out of time. But if you look at the data carefully, you can see that we decrease our mortality rate quite a lot with Caesars. I'm going to hop through this. I think one of the most important things about hysterectomies and morbidly adherent placentas and cesarean births is that once you adjust for all the other confounding issues that surround this, you can see that actually in terms of a planned Caesar, you have very, 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 very low risk of having a hysterectomy. In terms of perhaps an emergency Caesar after a very difficult attempted vaginal birth, it may be that your hysterectomy rate is a little bit higher, but we can't attribute that to Caesars. It's a complication of a vaginal birth. Infections, there are massive differences here between private and state emergency and elective procedures. Anesthetic complications are not always even avoidable with vaginal deliveries. And we've got good data to show that, anesthetics for regional anesthetics for spinals and for Caesars are much, much, much safer than they previously were. This is a bugbear, and I'm going to cover it quite quickly, but recovery is the same for a Caesar or a vaginal birth, and that's because most of the time we are recovering from the pregnancy and not the Caesar or the vaginal birth. The reason you can't run and exercise and do all of those fun things in the first 6 weeks is not because you've had a Caesar or a vaginal birth, but because you have got a lot of complications like joint laxity, you've got your pelvic girdle instability and all sorts of other things. And that's from the pregnancy itself. And it's common to both groups of delivery. So really this recovery sort of myth needs to also be put to bed. I'm going to pop through these things because we are running out of time. I just want to go through one or two little things here. The important thing to note is that even the guidance, although it is driven by faulty data, stating that a cesarean section with no indication should be offered after appropriate discussion and support. And that's an important. So what are we actually saying? Why should you have a cesarean delivery? Because you want one. It's as simple as that. And very quickly, because I know we are running out of time, I'd like to just briefly touch on the fact that I'm not even sure we should be discussing this. I don't know why anybody needs to justify their choice of how their baby's born, whether it's a vaginal birth at home in a water bath, or whether it's a planned and unnecessary cesarean delivery. I think that the stigma is completely unnecessary, and we need to change the dialogue around this debate. No more normal deliveries. It's just a vaginal birth. No more too posh to push. No more stigma at all. And we need to create a safe space where we don't glorify things that are essentially out of our control. We don't know. We can't force ourselves to have a vaginal delivery. It doesn't always work that way. And all of us in the space of women's health need to examine our own beliefs and work together to create a lovely space of logic and reason to allow for patient autonomy. And I'd like to just leave you with a little sentence that I found when I was looking through all the blogs of mothers that have had difficult vaginal births and ended up in emergency Caesars. Babies arrive in their own time and in their own way. And that's what we need to sort of remember here. That's what we need to keep in mind. Thank you, guys.
Thank you so much, Doctor. I'd like to now hand over to Dr. Francois Retief.
Thank you very much, Noe. I'm going to switch my camera on. There we go. And then 1 second, and then I'm going to share my screen. So this is now the other side of the coin, supposedly. Please let me know if you can see my screen, if it's sharing successfully. There we go.
Yes, we can. Thank you.
Perfect. Right, so I'm making the case for vaginal delivery or vaginal delivery, depending where in the world you're from. But to sort of echo what Francis has said, we thought this is a fun little bit debate, and it's going to be interesting to hear different people's take on this. But I think Francis is absolutely right. I think that the key part here is choice. Just to frame this a little bit regarding vaginal delivery, I think there's a lot of uncertainty or lots of different terms that get used. In medicine or in obstetrics, there's this 3-letter acronym NVD, which strictly speaking stands for a normal vertex delivery, which means, which relates specifically to the position of the baby's head. But it's sort of been translated as a normal vaginal delivery. And there's not really such a thing. So we've got this umbrella term, vaginal delivery. There's another concept or a term that gets used of a natural delivery. And I think often what is meant by that, it means that it's a delivery without medication, so without any pain relief, certainly without an epidural, and a delivery without assisted delivery. But for my purposes, I think we are just framing it as vaginal delivery as opposed to cesarean section. Because if you go into all the different intricacies of ways of having a vaginal delivery, we can go far beyond the hour that we've got to talk about this. So to frame this debate, I think it's important to realize that pregnancy is a unique medical situation that imposes its own resolution in the sense that there are only 2 options. It has to be either vaginal delivery or cesarean delivery, but it's got to be one of these 2. You can't not make a choice, and that puts a little bit of extra pressure onto this. And when women want to make an informed decision on how they would like to have their baby, their decision-making rests on perceived risks and benefits, sometimes in the first instance. And that's what I'm going to be looking at here, is the risks associated with cesarean section, appraisal of the perceived benefits of cesarean section, the benefits of vaginal delivery, and then appraisal of the perceived risk of vaginal delivery. But then at the end, also to echo what Francis has said, you end up comparing apples with pears and with oranges, and it becomes very hard to decide which one is which. And what becomes more important, I think, is what you want. And to decide what you want can be really hard. And the way that I pitch this to patients is say, think about what kind of experience you want from the delivery of your baby. Because it's something that's really quite a special experience. And most of us nowadays are not going to have many children. So it's one of those red letter days in your life that you're only going to get to experience a few times. And you want it to be as positive and a special experience as you can possibly make it. So the risks associated with cesarean section, you're going to see this is a full slide because there's so many risks. The ones that you can't have with the vaginal delivery, wound complications and infection, because of course with this vaginal delivery you don't have an abdominal wound. Postpartum hemorrhage is more common with cesarean section, and following on that, hysterectomy following postpartum hemorrhage is more common. And then you can also have anesthetic complications, which you, generally speaking, can't have with a vaginal delivery because anesthesia may not be involved there at all. To this point, though, this is where we need newer data, because a lot of the older data that shows big risks for anesthesia in cesarean sections, it relates to a time when routinely patients underwent general anesthetics for cesarean sections. And we know now that spinal or regional anesthetics, apart from being nicer because you're awake to see your baby as soon as it's born, is also much safer. Because you don't have all the potential airway complications that can happen with a general anesthetic. But even so, spinals can sometimes go wrong, and you can get spinals that go too high or spinals that don't work and need to be converted to general anesthetic, which of course is risks don't exist with vaginal delivery. And then a big one is the increased risks in future pregnancies. This is a big point I'd like to make. If you are planning to have a big family, it's important to realize that, as a rule of thumb, with cesarean delivery, each subsequent delivery becomes more and more complicated. So you've got increased risk in future pregnancies, the placenta preta or sticky placenta that doesn't want to come away. There's an increased there's a risk of uterine rupture from the scar. And what you find quoted in the literature is about 0.5% in women who go into labor. There's increased risk of obstetric anal sphincter injuries in women who then have a so-called VBAC or a vaginal birth after a cesarean section. It happens in 8% of those women compared to about 6% in women who have their first baby vaginally. And then this is an interesting and quite a scary one, increased risk of stillbirth in subsequent pregnancies. It must be noted, though, although this figure of 47% looks enormous, it just means a relative increase of risk. So it means something that is extremely rare becomes slightly less rare if you had a cesarean section before. And this is something that we really can't explain. And then the other thing with cesarean sections, if you planned it, if it's being done on demand, is that you may do this too soon. The one thing with spontaneous labor and delivery is that this labor happens at the time that the baby and the uterus have debated and decided upon between them. Whereas if you do a cesarean section, you may do it a little bit earlier, and this is then probably what explains the increased risk of respiratory distress in babies born from cesarean section. And then long-term things are so-called cesarean scar niche formation in the uterus, incisional hernias. And then, what I wouldn't say risks, but some drawbacks, is increased pain in the postpartum period, increased need for pain medication, poorer bonding, sometimes difficulty breastfeeding because it can be hard to do with an abdominal wound, and then longer recovery times. But then, important to realize that 6 weeks later, most women will feel the same, whether they had a cesarean section or a normal vaginal delivery. And then also important thing to realize is that the safety of your cesarean section depends on the operator, because this is something that's well proven, that the time that it takes to do a Caesar and the blood loss that is experienced during this surgery is dependent on the operator and their experience, and it becomes safer the more cases that they have done. And then to appraise the benefits, so safer for mothers, I really think it's hard to find data that's going to bear this out. Even the point being made that it's safer for women in terms of protecting their pelvic floor. For example, women who previously had normal deliveries and had obstetric anal sphincter injuries, which are these very serious tears, but if it was well repaired and asymptomatic, and you then compare that group of women who have cesarean sections versus women who have vaginal deliveries, the risk of incontinence is the same, regardless of which one they choose. So even their cesarean sections are not that protective. And then whether it's safer for babies, there are more respiratory complications. And yes, babies are less likely to have so-called low APGAR scores, which is an indication of how vigorous and how healthy baby is after delivery. But still, regardless, you can't prevent all incidences of cerebral palsy and neonatal admissions by doing cesarean sections before labor even starts. And then if we look at the benefits of vaginal delivery, first thing is it's likely to be successful. It's more than 90% successful in some settings. It does have the quicker recovery. And I think there's a sense of personal achievement if this is something that you wanted to do and you managed to get this done. It can be quite a life-affirming and personally affirming experience. And then there's quicker bonding, much lower maternal risks. And then again, to this point, if you're planning a big family, if you can get that first difficult vaginal delivery done successfully, each subsequent labor tends to be shorter, tends to be easier. The risk of tears is lower. So that is quite an important consideration. The perceived risks of vaginal delivery, so vaginal tears, and then what I mentioned, the obstetric anal sphincter injuries. And this is the big one, because this is something, if things go wrong, can have quite prolonged effects on quality of life. And then future pelvic floor dysfunction. But noted that these risks are low, 3 to 8%. And if they are managed well by experienced birth attendants, the risk of long-term problems is really quite low. And then, of course, things like the baby having to pass through the birth canal could lead to infections. And then, of course, you can have this unwanted outcome of emergency cesarean section, either because labor doesn't progress as planned or because we find signs of fetal distress on the monitoring. And it's in its essence, it's an unpredictable event. And this is something that one has to be mentally prepared for. And then the big one being birth asphyxia and cerebral palsy. And that, unfortunately, is something you can't get away from, that this is an inherent risk of giving birth vaginally, of laboring and giving birth, is that at some point baby can become short of oxygen, and that this can result in permanent damage. But we try and make it as safe as we possibly can. So this was an interesting study when I was reading a little bit about this. It compares risk acceptance of vaginal delivery complications between patients, midwives, obstetricians, and urogynecologists and colorectal surgeons. And this is sort of women rank these complications according to the level of risk they would be willing to accept. So the first one is like low risk. They would already rather opt to have a planned cesarean section. So the ones that I thought would be more important are highlighted in red. There's some of these that they listed. They listed 17 things in total that I wouldn't even consider a complication. I mean, pain during labor, that's just the nature of labor. It is painful. Forceps delivery perhaps, but vacuum extraction and emergency cesarean section is not necessarily a complication, but that's sometimes the way that things happen. But these are the things that they listed. Then severe anal incontinence, severe urine incontinence, moderate anal incontinence are the things that scare women the most. And then emergency cesarean section. So this is something that ranks a little bit higher perhaps than we realize in our patients' minds. What was also interesting in this study is that patients were willing to accept the most risk, followed by midwives, followed by obstetricians, and then the people who were the least willing to accept risks were urogynecologists and colorectal surgeons. So perhaps Francis and I are not the right people to give this talk, because we're likely to be quite risk averse. But yeah, and then the things that we need to talk about is that the cesarean section rate in South African private practice is very high. It's over 75%. And then that World Health Organization statement that the Caesar rate of over 15% is unlikely to confer further medical benefit in terms of outcomes. And then it raises the question is, why is there this huge discrepancy? And then the suggestion that maybe this is driven by healthcare providers. And there are some potential non-clinical considerations for decision-making, some push factors. And the big ones are specific to the way that obstetrics and private practice works in South Africa, where you've got a specific obstetrician who's going to be available for all their patients as far as they possibly can. And the reality of how this works is that a vaginal delivery is something that can take many hours. It can happen in the middle of the night. It can happen over weekends. Whereas a planned cesarean section is something that takes about an hour of time, and it can be scheduled very easily. And medical aids remunerate these two events the same. So clearly, it's almost a perverse incentive for practitioners to rather do cesarean sections. And then the so-called the perceived medico-legal risks that you are less likely to be subject to litigation if you do a cesarean section and have a bad outcome than if you perform a vaginal delivery and then have a bad outcome. The assumption is almost always that a cesarean section should have been done, and had it been done, it may have prevented this bad outcome. And that it's undeniably a very big push factor for obstetricians to be risk adverse. And then the convenience, which sort of ties in with the first point as well. But then the last point is what do women prefer? And this is not published data. This is just from my own private practice. So it's a small sample. It's over 3 years, 365 women who came for their first visit for pregnancy. And we asked them, it was just a very open-ended question, is how would you like to have your baby? Would you like normal delivery or vaginal delivery? Would you prefer cesarean section, or you're not sure? And more than half of women at the outset indicate that they would prefer to have a vaginal delivery. About a quarter prefer cesarean section, and of course that's something that one would want to respect. And then about a quarter are not sure, and if you assume that they would go about half each way towards the end of the pregnancy when they need to make a decision, the conclusion is that about 2/3 of women prefer to have a vaginal delivery if given the choice. And another corollary of this is that women are willing to trust their medical practitioner's advice. And therefore, it's very important for us it's our duty to give advice without considering the external factors. Because if we do, that's something that will do lasting harm to this trust, which is really, I think, key to the therapeutic relationship and what makes it such a special job that we do have. So in conclusion, I agree with Francis. This is about choice. And I think it's about deciding what kind of experience you want. I don't think that anyone will be able to sit and look at all these different risk factors and a 1% risk of a bladder injury and a 1% risk of a tear, etc., and look at those and make sense of it and be able to decide what kind of delivery they want. I think it's more important to think is this special event, if I could have it as perfect as possible, how would I want to have it? And then it's our job as midwives, as obstetricians, to make whatever the woman chooses as safe as we possibly can. In the absence of sometimes having absolute indications for one way or the other. But then also careful counseling so that women who choose to have vaginal deliveries are aware that things don't always work out, and that if things don't work out that way, that it isn't a very disappointing event, but that it still ends up being a very special and good experience for them. Thank you very much. That's the end of my section.
Thank you so much,
Sharing my
Doctor.
screen now.
I'd like to just remind everyone that you can leave your question in the Q&A section, just if you'd like the doctors to answer some of your questions. We are now moving to our discussion, and I'd like to discuss a few points this evening. Doctors, I'd just like to ask, what prompts the decision from a clinician view in terms of vaginal vs cesarean section?
Sure. I mean, it's a question that sort of is dynamic throughout the pregnancy, I think. You start off with what the patient is choosing and you form a plan. And I think the important thing is that you need to pivot if anything sort of deviates from the safety of the plan. I think that's the most important thing. You can have a plan and you can have your ideal, but you can't always predict what's going to happen at 12 weeks. You can't always predict what's going to happen at 38 weeks or 39 weeks. So I think that's sort of, from my perspective, that's what my choice with the patient is, and that's what our discussions is about, is that we sit there and we discuss exactly what our plan is, and that it may very well change.
And then just as a patient, then how much of a choice do I then have?
All the
Yeah,
choice.
I think I agree. That's all the choice, because it sounds maybe flippant, but it's your baby, so you can have it whichever way you want. I think perhaps to answer that previous question as well a little bit, so from a medical point of view, you can find, or there's indications for having a cesarean section that are present before labor. And these would be things like a breech presentation or a transverse presentation. So, I mean, these are babies that we know are safer to deliver by cesarean section. And then there are specific things relating to the placenta. So the placenta is covering the opening of the cervix. You know, there's no way that a baby can go through that closed opening, and it's something that certainly isn't safe. And sometimes we have babies that don't grow well. And we know that the stress of labor will be very likely to distress them. They're unlikely to get enough oxygen. And for them, a cesarean delivery would probably be safer as well. And then when you get to the things that happen during labor, there's two things that are quite common that commonly will lead to the decision to change from a vaginal delivery to a cesarean section. The one being if the labor doesn't progress. And we can't always explain it, and this is one of the frustrating things, but sometimes labor progresses to a point and it doesn't progress any further. And that is when complications occur. If you get a prolonged labor that's not progressing, and we know this is when things become unsafe for mom and for baby. And then the other one is then so-called fetal distress, where we monitor these babies' heart rates with monitors that get placed on mom's tummy, and we see patterns that show us that babies are not getting enough oxygen. And in that instance, sometimes we say, look, it's going to be safer to deliver this baby quicker, and sometimes the quickest way then is by cesarean section. But barring those things, and even in those situations, I think important to realize that the mom is at the center of decision making here, and no one can and no one should force a mother to do anything that she doesn't want, be that a cesarean section or a vaginal delivery. And I think that's where that trust is so important, that where patients trust us to advise them what's in their best interest and what's going to be safest for them, and to help them make decisions during labor and delivery.
May I ask them, doctors, when would you advise for someone to start seeing maybe a professional during their pregnancy, or just to start exploring some of their delivery options?
I think that it's the sooner the better, to be quite honest. I think that you should be sort of open to seeing your healthcare provider to confirm the pregnancy and to make sure that you don't have any risk factors, and make sure that you know when you need to be seen in the pregnancy, and discuss all sorts of options for fetal medicine specialists, etc., etc. And I think that then you need to see that healthcare provider for a time. And then I think it's important that if you have enough time, that if you don't find that you are sort of speaking the same language, that you have time to find another person who you think is better suited to you.
And your thoughts, Dr. Retief?
Yeah, I agree. I think sometimes even before falling pregnant, some part of what we do is also so-called preconception counseling, especially in women who've got medical conditions, where you can make things as safe as possible for them before they even fall pregnant. But yes, and the earlier the better, to start building that relationship, start having that discussion, especially I think for that quarter of women who are not quite sure what they want to do yet, which I think is fair enough, to start having these discussions, kind of what we are doing now in a form, so that they can start applying their minds and deciding what they would prefer.
I'd just like to ask a question that was raised in the Q&A section now. What is considered too early in terms of weeks of gestation for C-section delivery?
Definitely, I think that most of the guidelines will suggest that you deliver at 39 weeks. But, I think that anything before 38 weeks is too early unless you have a medical or a reason to deliver earlier if the baby or mum is in danger. But I think for a Caesar on demand or just a non-emergency Caesar, I think 39 weeks is probably optimal.
Yeah, the
Doctor?
consideration is too early, of course, then you run the risk of your baby being premature. And what that means really is your baby's not ready for life. And there's a few things that babies got to do on their own when they're born. The one is breathing, and then feeding. So if their gut isn't mature to feed and their liver isn't mature enough to metabolize and their lungs aren't mature enough to breathe, then they may need support and may get admitted to the neonatal unit. But on the other side, the further you go into a pregnancy, planning a Caesar, the bigger the chances that you may go into labor before that date. As we pointed out, labor is unpredictable. And then the drawback is something that you plan to have early in the morning in a very controlled fashion can then happen in the middle of the night, which can be a little bit scary and a little bit overwhelming. So we try and strike a balance. And I think I agree, 39 weeks is generally considered to be a very good point at which to make this decision. But if you want, you can, of course, wait longer because you do have choice.
Okay. No, thank you, doctors. I'd also like to ask, is it then possible to still have a vaginal birth after you've now had a cesarean section?
I think definitely it is. It also depends why you had that original Caesar. If it was medically indicated, you may need to, revisit your expectations. But certainly if it was an sort of semi-uncomplicated pregnancy and the reason for the Caesar wasn't something to do with your health, or a structural abnormality that is unavoidable in the second pregnancy, you certainly can do a vaginal birth after Caesar. There's nothing at all stopping you, and you just need to find the right person. And you need to make sure that when you speak to your healthcare provider about this, you need to know what requirements they have for this, and you need to make sure that those requirements suit you and that you're amenable to it. Because some people have got very strict guidelines about what they want you to do, and when they want you to come in, and how they want you to be monitored, because of the risk of a vaginal birth after Caesar. And some people won't. So you need to find that person that's aligned with your values.
Yeah, I agree. There are a couple of international guidelines. I think there's some instances where that really is not a good idea, but generally speaking, it's quite possible. And in the published data, the success rates are really good. You're looking at success rates in some places of as high as 80%, which is a little bit lower than for someone who hasn't had a cesarean section before, because there is a little bit of a margin of safety. The reason why such a big deal is made of a vaginal birth after a cesarean is because there is a scar on the uterus, and potentially when a woman goes into labor and she gets strong contractions, that scar can tear or rupture, and that is a potentially catastrophic complication. That you may lose your baby, you may lose your uterus, you may lose your life. So it is something that we take very, very seriously, and something that we are very apprehensive about. And because of that, for that reason, we are going to have very tight margins of safety. And for that reason, it's less likely to be successful. But even so, success rates are really good. So yes, the short answer is yes, you can.
Okay, doctor, I've had someone just ask in the chat whether or not you can still have a vaginal birth after you've had 2 or more C-sections. Specifically, I think 2 or more.
You strictly speaking, absolutely can.
Yeah.
The guidelines in the States and in the UK do allow for it, but under very, very special and very specific circumstances. And you are because of the inherent risk and the medico-legal environment, and also because we're also humans and we don't want bad outcomes for our patients as well, it is quite tricky to find someone who's willing to do a vaginal birth after more than one Caesar. We'll let Francois answer the rest of this, though.
No, I agree. So it is possible. And also preparation for this, I read a meta-analysis. So it's a combination of several studies that looked at different centers where they attempted this. So they had good success rates of 77%, which sounds very, very, very promising. But in all of these series that they published, they were in very specific circumstances. It took place in centers that are staffed around the clock with on-site obstetricians, where if there's any warning signs of rupture of the uterus, they were able to do cesarean sections within 30 minutes, which in general in South African private hospitals is not going to be the case. So from that point of view, I think it's going to be unlikely that you're going to find a practitioner who's willing to support you in this, because they know they can't do it safely, and I think that's important. Also to note that all of these studies, so they looked at 13 different series that were published, and in all of them there were at least one woman who had a rupture of the uterus. So that risk is real, and I think it's important in that kind of situation to have a long and careful discussion about whether this is worth it, whether it's worth the risk, and if you feel that it is worth the risk, is why, and really again dig into this and see. The goal is not at the end, one method of delivery over the other. The goal at the end is having a positive birth experience.
Thank you so much, doctors. Here's another question from our Q&A. How do you avoid tearing from a vaginal delivery if it is avoidable?
Well,
cesarean section.
Yeah, that would be good. No, but actually, it is important to understand that about 90% of people who've never had a baby before will probably tear during a vaginal birth, but it is very superficial. It's not something that necessarily will even necessitate stitches. But you must be prepared for it. And then I think prenatally, what you can do is you can try perineal massage. There are lots and lots of videos on the internet about this, and it has been shown to confer some benefit. And that's obviously before labor. And during labor, warm compresses on the perineum have been shown to help in the second stage, so at the very end of labor. And it's also important that you discuss birth positions with your healthcare provider, because certain positions, for whatever reason, are associated with tears and less likelihood of tears and a higher likelihood of tears. So, if you are perhaps intending to squat while in the second stage and delivering the baby, you may need to be prepared for a different risk of tearing as opposed to lying on your side, for example.
Yeah, it's there are a few things. Position, like Francis said, position during birth and perineal massage and so on. None of it has been proven though to completely take away the risk. So realistically, with the first delivery, you must be prepared to have some tears. And I think sometimes this comes as a bit of a surprise to women, is that your recovery after normal delivery is better than after a Caesar, but there's still a recovery. It's not like you are up and running a marathon the next day. Certainly not. Mm-hmm. In my experience, it's also a lot to do with the technique during the last part of delivery, being really slow and being really controlled. And it's something that I've certainly, over the years of my practice, I think I've learned to do better, to try and prevent tearing. But unfortunately, no.
All right, thank you, doctors. And what about having an induction? Does that change the delivery discussion at all?
Look, induction is generally reserved for indications like post-dates. So when the baby just is refusing to egress and you want the baby to sort of come out and join us in the world. And otherwise, when you need to deliver for fetal or maternal reasons, where the maternal preference is a vaginal birth. I don't know that induction I don't think that the Caesars that are done, as opposed to inductions, I think they represent a very small proportion of what we're actually talking about. I don't think that induction would replace Caesar in most of these instances, put it that way.
Yeah, I think the place of an induction is really there sometimes comes a point where we feel that a baby is better off delivered rather than staying inside, whether that's because mom has gone very far over her dates or so-called post dates, or whether there's something else, a maternal condition or abnormality in the baby or growth restriction in the baby, that baby's probably better off being born. And if we can choose, I think, spontaneous labor is always going to be better. Induction's more likely to end up in a cesarean section for several reasons. The thing is, induction is something that one sort of calibrates, and we can either underdo it and it fails and labor doesn't progress, or the labor simply does not start, or we overdo it and baby gets distressed. But those increases of risk of cesarean section is really not that much. So I think the consideration of an induction, I don't think really should play too much of a role in your decision of how you want to have your baby.
Thank you, Doctor. I have another interesting question here in the chat. Does vaginal birth really alter your sexual experience for life, or is it just a myth?
I think babies alter your sexual life. I mean, I think that's a given. You need to know that like things aren't going to be the same. But in all seriousness, no, your pelvic floor is key for, good sexual health. You need a strong pelvic floor. And unfortunately, there are numerous studies, and we know this, is that vaginal birth does cause pelvic floor defects. And to a certain extent, pregnancy does as well. But specifically vaginal births that are difficult, that are prolonged, that you have to use a vacuum or a forceps to pull the baby out, your pelvic floor is inevitably going to be damaged. And I mean, that goes to Francois' point about, whether the second Caesar is protective after you've had a tear. It's not, because the damage has already happened. That first delivery is when it happens. It's irreversible. So whether you have another vaginal birth or you have a Caesar, it's not going to make a difference. So I think that you do need to be prepared for a certain alteration. And, you hope for the best, but you need to prepare that it may very well happen.
Dr. Retief, do you have any comments on this?
No, not really much to add. I think perhaps to point out that it may, I think that exactly as Francis ended up, is yes, it may. You may have injuries that's going to affect your perineum. You may have perineal tenderness. You may have painful scars, and that you've got to realize that's also a real risk of vaginal delivery. But it certainly doesn't happen to all women, so it's not a guarantee that that your sex life is necessarily going to be different.
Thank you. Just the last question from our Q&A section. Does the bone structure and size of a person influence the type of delivery?
From my perspective, not really. I don't think you can judge how a baby is going to move through someone's pelvis because they're small or they're big. It happens where you have very, very tall people with very, very small babies that aren't able to be delivered vaginally, and vice versa. And I think the main predictor of a successful vaginal birth is how the baby is lying. Even if you have a very big baby, if they're lying very nicely, and the mechanics of the birth are good, you are going to do pretty well. There's quite a lot of evidence now on pelvimetry. They are doing new sort of MRI pelvimetry where they measure the pelvis to try and see whether this is going to be a successful vaginal birth, but none of it really has good correlation to clinical practice. I mean, we're hardly going to MRI people, you know, on a daily basis to see whether their pelvises are wide enough for a baby. At the end of the day, the only way we know if a vaginal birth is going to be successful is by attempting it.
No, that's very true. That's the only real test of your ability to deliver is to try. There's no other test that can predict whether you're going to be successful or not. The bone structure is not that important, but I think it's something to maybe to be aware of is that your BMI, so your body habitus does play a role. We know that the obesity crisis in the US has risen over the years, and the rates of obesity have increased dramatically from sort of the 70s to the current day. And there are some studies where they draw a link between that and there's a tendency towards labor being more slowly or going more slowly, or is more likely to progress, not to progress well. And I think that also speaks to the fact that labor and delivery is quite a physical event. And it's something to consider if you are preparing for a pregnancy or you're preparing for a labor and delivery. This is something that takes quite a lot out of your body. And of course, the fitter you are, the healthier you are, the easier it is going to be.
Thank you so much to you both, doctors. And I'd also like to thank everyone who's joined our chat tonight. I think this was a very robust conversation. We have left the Netcare app link in the section below, I think in the Q&A section. So if anyone would like to download the app, I think they should download and register just for them to start booking their gynae appointments and making sure that they're ready for pre-admission. Thank you so much to everyone for tonight.
Thank you for having us.
Thank
Good
you.
night.
It's been a pleasure.